Hello and welcome to our presentation of Living Positively with Inflammatory Bowel Disease. My name is Catherine Mulvale and I'm the Executive Director of the Canadian Digestive Health Foundation. Thank you for joining us for this special session. The Canadian Digestive Health Foundation is here to help you. We are the foundation of the Canadian Association of Gastroenterology, and we are supported by physicians and scientists who specialize in digestive health and disease. It is our mission to empower people like you to take control of your digestive health with confidence and optimism. Our objectives for this evening are, first, to welcome you and let you know that you, as someone who is affected by inflammatory bowel disease, you're not alone and there is hope and solutions for you. Next, we're going to introduce you to an individual who is living with Crohn's disease and a medical expert who will help you better understand IBD. And, as I said before, we're going to answer as many of your questions as possible. The Foundation would like to thank Merck Canada for sponsoring this event with an unrestricted educational grant. Merck is a strong supporter of the Canadian Digestive Health Foundation, and without their support, this session would not be possible. We hope to provide each of you with valuable information that you can use in your everyday life when speaking with your physician and making decisions about your health. We have two speakers with us this evening ready to share their insights and expertise with you. First, you will hear from Jeff Schechter. Jeff has been living with Crohn's disease for 15 years. His symptoms are now under control, and he's living a full and happy life, but it hasn't always been this way. As a teen, Jeff suffered through typical symptoms, the embarrassment those with IBD are forced to live with, and the side effects of various therapies used to help control his disease. Jeff is here to share his journey and answer your questions. Welcome, Jeff.
Thanks, Catherine. Nice to be online with everybody. I was asked to speak today to try and give over some insights into my experience living with Crohn's disease. The slide that we're looking at now says I have an IBD, but it's specifically Crohn's. And I started out, I think, typically the way that a lot of people do, in that I was having a lot of stomach aches when I was around 15 years old, so I was almost just over 20 years ago. And, I went through the standard GP and referred to a specialist, and they said that they weren't sure what I had. It could have been irritable bowel syndrome, which is sort of a catch-all for something that's going on. And then eventually they diagnosed me with Crohn's disease. And at the time, the drug of choice to keep everything under control was prednisone, which works really well keeping Crohn's under control, but it's got a lot of side effects that are really less than fun to live with. I lived like that for almost 10 years, and Dr. Fedoruk, who's going to be joining us later, became my physician due to my previous retiring, and he very much instilled in me that the quality of life for a patient living with IBD is paramount. And I remember I was actually really ill when he first found me. And he called me and said, I got all your blood results back and all your tests, and you need to come to the hospital right now. I told him I didn't understand why. I thought everything was okay. And he told me he didn't know how I got out of bed that morning based on what all the blood results and everything I had. I told him, I thought that was odd. I went snowboarding the night before, and he's like, I don't know. You're a different person in real life than you are on paper. So I went to see him and was actually hospitalized shortly thereafter and received blood transfusion and iron transfusion, IV this, IV that. It was poked and prodded. But eventually he's got me shortly thereafter feeling so much better than I had. And, as a follow-up, he looked me in the eye and he said, you just forgot what it's like to feel well. And I tell everybody that has any type of IBS or IBD, I give that exact quote over. Crohn's is one of those things that, if you have it, it's, I guess whether genetically or whatever, there's that side to it. But unless it's bothering you, it doesn't really affect your life. And when it is bothering you, you think of nothing else but. You're always looking for, where the nearest bathroom is, what social setting you're going to be in. If you're in an active flare, you realize that the only thing at the forefront is how I can't eat this and I can't do that and I have to be close, and I don't want to put myself in a situation where I got a 3-hour car ride with a bunch of friends because they're going to be making them pull over every 45 minutes to go to the washroom. So it really adversely affects people if they choose to let the disease control them versus having themselves take control of the disease. So I found, there's a few things that really make a huge impact while living with Crohn's. First and foremost is find a good doctor. There's a lot of people out there that just think that they can self-manage or self-medicate with, topical or over-the-counter type remedies. Well, it may be a bit of a Band-Aid. It really is doing themselves a huge disservice. There's a lot of great drugs that are coming out, a lot of treatments that make such a world of difference. And if people either realize it's out there, I think they'd be more proactive about utilizing all these resources that are available to them, and even forums like this where you can. Everybody that I meet that has a Crohn's or a colitis, they ask me all the same questions. What do you do about this? And everybody runs through the same 15 or 20 questions the whole time. And it's great that the CDHF and Merck are putting this kind of session on because information is power. In most things in life, but really, especially with this type of disease. So once you find that you have a really good doctor, you really need to discuss again the quality of life issues and let them know all the things that are bothering you. And certain things bother certain people differently, and a lot of therapies and lifestyle choices can be customized or tailor-made to suit the person. There's a lot of biologic drugs that are out there right now, like a Remicade and a Humira. I'm sure Dr. Farag will speak to those later on, but some of them are do-it-yourself shot at home, and some of them are an IV you have to go to the hospital for. So, if somebody's not comfortable doing that type of thing, they can go from one drug to the next. If they don't like it being poked, there's oral medication they can take. But that's something that a person's doctor would be able to discuss with them and really make a huge impact in improving their life. Coming up to drugs, it's so important to take meds. I used to be one of those guys, I used to tell my doctor this the whole time, that I thought I knew better than everybody. I'd self-medicate. He put me on a particular program or regimen, and I'd, start off with gusto for the first little bit. You start feeling better, usually fairly quickly, and then people start to trail off. They don't want to take it. They don't like the side effects. They think they're well, and it doesn't really let their body heal properly. And they slip into this cycle. If it's something that's like an antibiotic, it's even worse because you can build up a resistance to it. So it's really important for people to know that if their doctor prescribes them a particular routine, they have to stay on the drugs exactly the way the doctors have told them if they want to get well. And a lot of times it's just as simple as that. Take your meds, do what you're supposed to do, eat what you're supposed to eat. And it sounds easy, but it really is. And if a person's, usually they have to hit rock bottom and they have a really terrible time of everything. And then they realize they just have no other option. They do it and they feel well, and then it's just a maintenance course. So with the drugs is one aspect that you can do, and there's a whole slew of them that are coming out. They're just fantastic. The other thing is managing your diet. A lot of people have, if you're lactose intolerant, it aggravates things by increasing mucus in the GI tract. People, I'm a big spicy food kind of guy, and it's just a no-no. It just sends your guts it just wreaks havoc on your body. Things like seeds and nuts and coffee and all the good things in life. When you're really in a flare or your guts are bothering you, it's really putting salt on a wound. So if you can try and tone down the things that aggravate your gut, you get to really over the years living with it, you have a really good understanding of what the triggers are for yourself. So if there's certain foods you can stay away from, and you have to stay away from, you do so. If you try some that, even the doctor says is a no-no, but you seem to tolerate very well and it doesn't bother you, then you can incorporate those back into what you have. But again, it's all about the discussions you have with your doctor and keeping track of what you eat and when you eat it and what symptoms arise from that whole situation. And the other big thing, in my life, and I've read this in a lot of Crohn's literature, is stress. And that, it's very nice to say you don't want to get stressed out in life, but it's a huge impact. You can take your meds and you can eat really well and you can exercise, but if you're just bombarded with, everything that everybody has in their life to deal with, again, it could be the one thing that just sets you over the edge, and then everything else after that just exacerbates the entire situation. So as best as possible, if you eat fairly clean, you listen to your doctor, you try and, keep your life somewhat sane, you can live relatively symptom-free for a long period of time. I've been like that for quite a while. And everybody goes through those bouts, but it gets easier and easier to get under control and to maintain that nice, even keel throughout life. And as everything progresses, I think the drugs are going to get better, and the periods of remission will get longer and longer, and you'd be able to basically live your entire life with an IBD and hopefully really become symptom-free. And in that case, you might have Crohn's, but if it's not affecting your life, you don't have to worry about it. So, I mean, those are some of the insights that I've had. I'd also recommend, if get active in Crohn's disease. The CCFC is a great organization. They have golf tournaments throughout. They raise money. It stays local. The CDHF, is a fantastic organization. They do things like this to help, foster education and improving the well-being for, everybody with an IBD. And the Internet's a fantastic resource too. There's a lot of information on there. There's an app I know that we're going to speak about later that's fantastic, the My GI Bodyguard, that allows people to, track their symptoms and keep a really specific log as to what's going on, that is going to help facilitate doctors improve the quality of life for those people. So I'm really excited with everything that's going on. The past few years for me have been leaps and bounds better than they used to be. I hope anybody that's logged in today and listening is going to take at least something to heart, from what I've said, and go see their doctor and ask pertinent questions and get better.
That's great, Jeff. Thanks very much for sharing your comments and your story with us.
My pleasure.
Next, we welcome our expert, Dr. Richard Fedorik. In addition to being the Associate Vice President of Research at the University of Alberta, Dr. Fedorik is also our President. Dr. Fedorik received his medical degree with first-class honors from the University of Alberta in 1978. A recipient of numerous awards, research fellowships, and grants, Dr. Fedorik is recognized as an expert in inflammatory bowel disease. He has an active basic gastrointestinal research laboratory, serves on multiple national and international scientific advisory boards, has published over 400 peer-reviewed manuscripts and book chapters, produced 2 patents on colonic-specific drug delivery, and has lectured around the world. Dr. Fedorik has served as president of the Canadian Association of Gastroenterology, president of the University of Alberta Hospital Medical Staff, president of the Alberta Society of Gastroenterology, and of the World Congress of Gastroenterology Bid Federation. He's the general secretary of the Pan-American Congress of Gastroenterology and has served as president of the World Congress of Gastroenterology. Dr. Fedorik hopes to share some of his insights with you tonight and show how an improved understanding of inflammatory bowel disease can lead to lifestyle changes and treatments that offer better disease control and a better quality of life for you. Welcome, Dr. Fedorik.
Well, thank you, Catherine, and hello to all of you out there attending on this webinar. And thank you to Jeff, who had some really important words, I think, of wisdom for all of us to hear. My job is to spend the next 10 or 12 minutes going over some information on inflammatory bowel disease that I think will help all of us, help you just gain a better understanding. As you listen to some of this information I'm passing on to you, please write down your questions and submit them, and we'll try and get to all of them, or as many as we can at the end. So we're going to talk a bit about your understanding of inflammatory bowel disease. I'm going to chat about the signs and symptoms that you might have, tests and diagnosis that need to be done, talk a little bit about the therapeutic options, treatment options, some of the complications that we see and how we might manage them, and then most importantly, how you can live positively with IBD. And we'll come back to Jeff for some more words of wisdom on that. So let's just go through a bit about understanding of IBD. There's really 2 separate disorders when we talk about IBD. There's ulcerative colitis, which is an inflammation that affects only the large intestine. And then there's Crohn's disease, which is an inflammation that can affect both the large intestine or the small intestine. Both of these disorders are going to lead a person with some malnutrition because you're not able to eat well enough, you have diarrhea, and we're going to be able to see on your blood tests changes and disorders that will help us identify whether you have inflammatory bowel disease. Interestingly, IBD affects people in the prime of their life. This is a disorder that usually comes on between ages 15 and 25. And you'll all recall that's the age when you're either trying to get a job, you're trying to go to school, you're getting married, there are major changes in your life happening, there are important social economic changes happening, and you're having this inflammatory bowel disease with pain, cramps, and diarrhea. Many of these symptoms that people get actually change the course of an individual's life because they're not able to complete their schooling, they're not able to get their job they want, and it really has potential for changing career. So my job as a physician is to get to that person, educate that person about their IBD, get them on the right treatment, and allow them to lead, as Jeff says, a normal life. If you look in Canada, there's 200,000 people with inflammatory bowel disease in Canada. Interestingly, it's one of the highest in the world. So for some reason, there's more inflammatory bowel disease in Canada, and there's more inflammatory bowel disease in Alberta and Newfoundland than there is in other provinces. And we're working as researchers to try and understand why that is, because somewhere in there is a hint to the cause of this disease. And it's expensive. So Canadian society spends about $1.8 billion, with a B, dollars in treating patients with inflammatory bowel disease. So that's a ton of money. And we need to find better ways to treat this disease that are less expensive. And part of that cost comes from the fact that 1 in 20 patients with inflammatory bowel disease, like Jeff mentioned, are hospitalized each year with their inflammatory bowel disease. And many of those patients that require hospitalization go on to surgery. Not only is there disease that affects the large and small intestine, but many patients with inflammatory bowel disease also have the same type of inflammation that's in your intestine is in your joints, in your eyes, your skin, sometimes in your liver or your gallbladder. And so you get inflammation in other parts of your body, again, that lead to difficulties going to work, difficulties going to school, and often hospitalization. So let's take each of these disorders one by one. The picture you should have up in front of your screen is a picture of someone with ulcerative colitis. On the left-hand side, should be your left-hand side, you'll see a picture of a stomach, in the middle the squiggly small intestine, and then the large intestine exiting out in the rectum. And ulcerative colitis only affects the colon. In this picture here, it's that red area of the colon, the left side of the colon, that is affected with inflammation. The colon is normally lined with something like your skin. It's smooth and shiny. In ulcerative colitis, that lining, the colonic intestinal lining, wears away. The analogy would be as if you were riding your bike and you fell off your bike and skinned your knee, and now your knee is red and raw and bleeding. Well, inside the colon, the lining, or the skin, the lining inside that colon has worn away, and it's red and raw and bleeding. And that leads to pain, cramps, and diarrhea. Because that lining has worn away, any material, any fecal material or any digestive juices that come in contact with that lining of the intestine are painful. Again, an analogy would be if you had a cut on your finger and you poured vinegar or lemon juice into it, it's painful. Well, imagine having the lining of your intestine worn away like a large cut, a large ulcer, and you're pouring digestive juices into that. It's painful. And your body feels that as pain, cramps, and because your intestine doesn't like all that pain, you end up with diarrhea. Now, as that lining wears away, little blood vessels are exposed. And so when you have blood vessels exposed, you get bleeding. And so these people tend to have bloody diarrhea with your ulcerative colitis. And because you're bleeding, it leads to anemia, and then you become fatigued and dehydrated. Another important part of the symptoms with ulcerative colitis are something doctors call urgency and tenesmus. The rectum that we have is like a reservoir. It allows any fecal material to be held there so that we have time to go off to the bathroom at our leisure. But if that rectum is inflamed, then it doesn't have capacity to hold anything. And even 1 or 2 milliliters, 1 or 2 ounces of fluid in there will cause that rectum, that colon, to really contract down hard, and people can't wait and hold it to go to the bathroom. We call that urgency. And there's another word called tenesmus, which means painful. So people have this small amounts of fluid, and they have to rush off to the bathroom right away or risk soiling their underwear. So those are the classical symptoms that we see with ulcerative colitis. Now, to diagnose ulcerative colitis, it's become relatively easy. And we've shown you a picture here of someone's colon with a colonoscope. A colonoscope is a long, flexible tube with a little video camera embedded on the end, so that we can pass this flexible tube, easily slide it up the large intestine into even the small intestine here, as you see right at the end, that colonoscope sliding into the ileum just by the appendix. But that allows us to see the lining of the intestine. And it's probably the most important test that a person can have to make that diagnosis. And almost everybody that has ulcerative colitis has had a colonoscope. And that colonoscope, through there, we can also take biopsies. And those little tiny pinch biopsies, which are painless, we can look at under the microscope and make the final diagnosis. We've listed also a couple of other tests. Barium enema, that's an X-ray where we put barium up the bum. A CT scan, which is a computerized X-ray that can also give you pictures of the large intestine. But colonoscopy has become the test of first choice for ulcerative colitis over barium enema and a CT scan. Now, I list stool culture there. Many of your doctors will have asked you to get a stool culture, a stool sample, to send that into the laboratory for analysis. And that's because some infections, some food poisonings, as a matter of fact, can give you pain, cramps, and bloody diarrhea. And it's very important to be able to distinguish that from ulcerative colitis. So your doctor will ask for a stool culture before making the final diagnosis. So I've covered a little bit about ulcerative colitis, and I'm going to move on and talk about Crohn's disease. The picture you have up in front of you, this gentleman, is Burl Crohn. He is the gentleman who first described this disease. He was a physician, actually a surgeon at Rockefeller University in New York City. And he described it along with a couple of his colleagues in 1932. But actually, if you look back, this disease was first described in 1913 by a Scottish physician. I'm telling you a little bit about the history because it's important to know where this all started from. But since 1932, we've been tracking the amount of Crohn's disease and ulcerative colitis in the world. And the incidence, that means how often it's occurring, the frequency that we see this disease, is rising a lot. And it's interesting that we don't see this disease, Crohn's disease, or even ulcerative colitis, in developing countries. So I've had the opportunity of traveling to South America and to India and to China, and they don't have inflammatory bowel disease. But we do have inflammatory bowel disease in developed countries, United States, Canada, Australia, Western Europe. So something about the developed world is allowing this Crohn's disease to explode. And then if you take a developing country, and I'm going to use Brazil as an example. So 20 years ago, Brazil had no Crohn's disease. Today, Brazil, a much more developed country than it was 20 years ago, has an incidence or frequency of Crohn's disease that's not much different than Canada. So again, as I said, there's something in there that we need to learn and study, because something in that is telling us what the cause of this disease will be. And we can talk about that more in the question period. Let's now look at some understanding of Crohn's disease. And again, got that same picture up there. This is a person, and you see their swallowing tube, their esophagus, their stomach in that picture, the squiggly small intestine, the large intestine. And we've highlighted on that picture, or you should be able to see the areas of the intestine that are redder. Well, that's where Crohn's disease can attack. And as you can see, it's not only limited to the colon as it was in ulcerative colitis, but it can attack anywhere in the intestine, from the mouth all the way down to the anus. And often there's skip areas. So you may have some Crohn's disease in the stomach, some in the small intestine, and maybe some in the large intestine. So that's how doctors distinguish ulcerative colitis from Crohn's disease, is mainly its location and the fact that Crohn's disease has these skip areas in different parts of the intestine. I want to talk a little bit about the signs and symptoms of Crohn's disease. And you'll see this list that we've put together here is not much different than it was for ulcerative colitis. And words such as pain, cramps, bleeding come up again in Crohn's disease, just like in ulcerative colitis. And it's because the same thing has happened. The lining of the intestine has worn away. In ulcerative colitis, that only occurs in the colon, but in Crohn's disease, it can occur in many different parts of the intestine. But the patient still has pain, cramps, and diarrhea. I want to point out one other thing. And in that first bullet point there, you will see failure to grow in children. And you'll see the word weight loss and malnutrition. We see that in Crohn's disease much more than we do in ulcerative colitis, because people who have Crohn's disease in the small intestine, people who have Crohn's disease in the stomach, get much more in the way of pains and cramps, and they tend not to eat because they know that they can avoid the pains and cramps by not eating. Children especially are good at that. They get cramps, they don't eat. They don't eat, they don't grow. And so that's another problem that we see with patients with Crohn's disease. Again, the diagnosis of Crohn's disease, as you can see here, much the same as with ulcerative colitis. We rely upon the colonoscopy to put the tube into the large intestine, take the colonoscope and move it into the small intestine, take biopsies, look under the microscope, find out where that Crohn's disease is, define its extent and severity. We will also use small bowel follow-throughs, which is an X-ray where you drink barium to look for Crohn's in the upper intestine. We'll use CAT scans, CT scans, to look for Crohn's in the upper and mid-intestine. There's new tests now, wireless capsule endoscopy, where you actually can swallow a little video capsule. It's the size of a large pill or tablet. It takes about 72,000 pictures as it moves through your intestine. And in that 8-hour video of your inside of your intestine, we can actually watch it on the screen and identify where ulcers are and where Crohn's disease is. And once again, we'll take a stool culture to make sure that you don't have food poisoning or a bacterial or parasitic infection that could mimic your Crohn's disease. In the next couple of slides, for the next few minutes, I just want to tell you about complications. And these are Crohn's disease complications. Crohn's disease, because it involves all layers of the intestine, leads to scar tissue. And the picture you have in front of you is a picture of the cecum, and there's the appendix, and then there is an intestine, and you'll see in the cutaway of the intestine shows a little colonoscope peeking out, and then a balloon being put through a narrowed area. So when we have that scar tissue, sometimes we try and avoid cutting it out, and we can put in through the colonoscope a balloon, and we can open up that scar tissue. It's like doing surgery inside you, opening up that scar tissue, stretching it open so that now things will move smoothly through there and you'll have no blockages. Other times, you'll have one of these scar tissues, one of these narrowings, and with that narrowing, you can't eat properly. Every time you eat, food gets stuck. Every time the food gets stuck, you get pain, cramps, and nausea. And maybe the balloon can't reach this area. Maybe the balloon is not sufficient, and so you may have to go for a small surgery called a stricturoplasty, where the surgeon will open that scar tissue up, stretch it up, and then sew you back together. So it's another way in which we deal with patients and their complications. Also with Crohn's disease, I've shown you another complication here, and that is Crohn's disease as a transmural disorder will also sometimes lead to fistula. Fistula are little ulcers that start growing and growing and growing and gradually burrow their way right through from one part of the intestine to another part. When those fistulas occur to sensitive areas such as the bladder or to the skin, they sometimes need surgery. Other times, small little fistula occur and we can treat them with medication. Which brings me to the last thing I want to talk to you about, and that's treatment. And I'll leave this slide up for a while so we can all look at it. But I've drawn here a pyramid. And doctors think of the treatment as sort of a pyramid. At the bottom of the pyramid is the simplest treatment, and at the top of the pyramid is the most aggressive treatment. And many of you attendees on this webinar tonight will be on one of these medications. You might recognize them. And you'll be on one of these medications depending upon how severe your disease is. So if you have very mild disease, you might start with an antibiotic or something called mesalamine. Trade names would be Azicol or Celifulk, Mesacel. And if that didn't work, your doctor might put you on corticosteroids, and trade names there are prednisone and budesonide. And if that wasn't sufficient, your doctor might put you on an immunosuppressant agent. Trade names there are Imuran and 6-mercaptopurine. And if that wasn't working well enough, they might put you on biologic therapy, and trade names there are Humira and Remicade. And then there's experimental therapies, which are still in development, and ultimately, sometimes none of the medications work, and your doctor might recommend surgery. But it's this pyramid approach that has served Canadians well for a long time, and it's an approach that we still use, but it's important that you and your doctor identify where your disease is, how severe it is, and like Jeff told you, identifying how severe his disease was and then initiating the right therapy at the right time so that he could get back to a normal life. So I've told you a little bit about what Crohn's disease is and ulcerative colitis is. I tried to talk to you a little bit about the complications, something about our treatment that we use. But the most important thing is living positively with this disease. And I've listed a few things here, and I'm going to ask Jeff to come and talk a bit further. It's important to take your medications. You need to find a physician who knows something about inflammatory bowel disease and to make sure that you have regular visits with that individual so that he or she knows what your disease is and how you're responding to the medications. Jeff has talked a bit about food. Food and diet will not treat this disease. It will not cure this disease. But there are foods that are trigger factors for people that can make some of their symptoms worse. Similar with stress. Removing stress won't cure this problem, but some stresses will aggravate symptoms, and so you need to be aware of that. And finally, it's going to be really important to track your history, to bring to your doctor what things have made you worse, when you got worse, what medications made you better, and what medications didn't. You have to have a constant dialogue with your doctor so that you and he can manage this chronic disease that currently is not curable and that you're going to need some medication, some treatment, some follow-up for life. But maybe now I'll turn it back to Jeff, who's been a patient with this disease, to tell us a bit more about how he lives positively with IBD. Jeff?
Thanks, Doc. Really, I mean, to elaborate more on what I was speaking to earlier, taking medications is prescribed. So as you went up your pyramid of drugs, a lot of these drugs also, they're used, and I learned this very early on with Dr. Fedorik, they're used in combination with each other, and they can either enhance each other or they get rid of one problem, so it allows the next drug to work really well. So, for instance, I still am on Humira. It works fantastic for me. Part of that protocol was to ensure that I was taking Imuran, which was an immunosuppressant, at the same time. And a lot of these drugs also take a little while to ramp up, so that, if you start a Humira protocol, you don't necessarily, and I'm not a doctor, I don't know all that, I just know what I've been told, but there's a period of time of 1 month, 2 months, 3 months where the drug reaches its full effectiveness. So in the meantime, you're exposed still without a full coverage of drug therapy. So it's really important to maintain the existing drug that you're on, and then let the other one come through, and they either work together again, hand in hand. And a lot of times you can wean yourself off under doctors' guidance from one drug if it's either not required or you seem to be handling your symptoms very well, and you don't necessarily want to have the side effects of other drugs. Prednisone, I have a lot of friends that they come to me and they ask me. I've dealt with this a long time. I'm very active in the digestive health forums where I live in Edmonton, but it's got it's got a bad rap because it's got some really ugly side effects. It causes you feel like your hands are really swollen, and there's you have a voracious appetite. You can eat and eat and eat. It causes some people to break out. It causes for me, I got night sweats and this, but it really, I don't want to say cures the disease, but it really has a huge effect on the symptoms. They almost disappear. The one hook to prednisone is that when you come off prednisone, you have to wean down off it on a very gradual basis. And I'm sure Dr. Fedorik, if people have questions, he can probably explain why. But for myself, again, I was self-medicating. I'm like, oh, you know what, just stop. I feel better now. And I realized after doing some research on my own, it's a very dangerous thing to do, to just decide to stop all that kind of gradual process. So and the same thing with antibiotics. It's really one of the annoying sides of taking these drugs is that there's just such a large quantity. I remember at one point I was on ciprofloxacin, which is an antibiotic. I was on Flagyl, which is a different antibiotic. I was on Imuran for immunosuppressants, prednisone, up to like 8 to 10 of these little tiny white pills a day. And just to keep track of all that and to keep your head wrapped around, and some of these pills you're reducing by half a pill at a time. So, and some you need, you can run one course of antibiotics and you need to keep the other one going. So, to keep a proper record of what you're doing and how you're doing it is also very important. I know we spoke to food choices before. Some foods, again, I said spicy foods, lots of foods with dairy that cause a lot of mucus buildup and stuff. And again, I'm lactose intolerant, and I don't know, maybe Dr. Fedorik can fill people in. I don't know, a lot of people that I speak with that have IBDs are also lactose intolerant. I don't know if it's just a fluke or if more people are like that or more people are aware that that's an issue for a large population. I'm not really sure, but if you stay away from spicy foods, if you stay away from nuts and seeds and any little tiny things that get caught as they're traveling down your digestive tract, they can just sit there and scrape along. Really fibrous foods, again, are I find myself are really aggravating to me because, especially if you're in a flare, Dr. Fedorik gave that example of it being like a skinned knee. So, and he explained that to me the exact same way, that if you have food and it's traveling down your digestive tract on an open wound, you want something that's, very neutral and very soft and very easy to digest versus something that's really coarse and spicy, or it's got a lot of acidic quality and quantity to it. So you don't really have to restrict yourself, and you learn, to be honest, you live without this for a while and it almost becomes distasteful for you. So it's not, at the beginning you might miss it. I mean, I loved coffee, but I can't drink coffee anymore because it's just, it just aggravates my stomach to no end. So after a while, I've just lost the taste for it, and it's one of those things, you live with it long enough, and I think you just come around, and you prefer your quality of life and being symptom-free and pain-free rather than that cup of coffee. And I know last thing that I was looking on that slide was track your digestive history. And I don't know if Catherine is going to get to this Bodyguard app that the CDHF has developed, but it's a fantastic tool to do all of the above, everything that we've spoke about during this webinar. It allows you to track your food and your water intake and your pain levels and how often you go to the washroom and is there blood in it and what frequency did you have and what foods you're eating and what your stress is like. And it's able to actually keep all that data, and you can send it to your doctor so that if it's your first-time consult, it's one of those things I've gone through the rigmarole a few times, and all the docs ask the same questions, and if they say, well, how long have you been having stomach aches for, and it's the first time you've been to your doctor because you just can't stand it anymore, it could be like a year or 2 or months, and you don't remember what you ate 6 months ago and the meds you were on, and did you really come down properly or not. So I really think this app is a fantastic tool that's going to, first of all, help doctors cut to the chase much more readily than they ever have before. It's going to give real-time data to those guys, and also to yourself. You can look through it, and if you're eating something and you notice that you have symptoms in a short period of time right after, you're going to know that's a potential trigger for you. And everybody's different. Spicy food might not bother some people. It might be the death knell for others. So somebody should for sure speak to that here, because I'm blown away by it. I think it's a fantastic tool and something that I think will make a real positive change for people's lives living with IBD.
So I think Jeff just did introduce you to My GI Bodyguard, which will be available for the public for free very soon. So we'll keep you informed about what's happening with the progression of that. I believe all of you are now signed up for our newsletter, so you'll see that as soon as it's available. We'll let you know so that you can get your hands on it and start playing with it. Jeff was actually very much involved in the development of it, so he knows firsthand what needs to be tracked from a patient's perspective, and we have our gastroenterologist to advise us on what the physicians actually need to see, and we have great reviews from both of them. So we'll be really, excited to share that with you. So thanks, Dr. Fedoruk and Jeff, for going through your presentations. We do have several questions, so I think I'm just going to start going through those. So the first one is from Myrna, and she says, can you still get the nutrients from foods when they're not totally digested?
Myrna, it's Richard Fedoruk here, and yes, you can get most of the nutrients. Your body is very innovative in extracting nutrients from food, and unless you have a large section of your intestine removed, you can get all of the nutrients you need and survive quite well even with 50% of your intestine removed. So there's quite a reserve the body has in being able to pull out nutrients out of food.
Great. And then we have a question from Colleen, but it's a question that has come up probably 12 times through the registration and also through this evening, and that is, how can I combat the chronic fatigue that I suffer from?
Well, I'll ask Jeff to also answer that. What I would say is two things from a doctor's standpoint. One is to identify that chronic fatigue is often there because your body is fighting against the ulcerative colitis or Crohn's disease, and so it doesn't have much reserve left, so you're tired. The other is your doctor needs to make sure there isn't other reasons why you're fatigued. Are you anemic? Is your B12 level low? Is your iron level low? Is your thyroid working properly? All of these things can be abnormal in patients with IBD, and so they need to be checked. So those are the two doctor comments, and I don't know, Jeff, do you have any words of wisdom on how to get through some of that fatigue?
Yeah, well, the same thing for me. You know, one of my biggest symptoms is that I used to bleed a lot, and I've actually had a weird progression. I had a lot of cramping and stuff when I was younger, and then it turned into, you know, I had to have a couple minor surgeries and infections were happening, and then it turned into really just bleeding. That was my biggest side effect, which was obviously something very severe, and that's what triggered Dr. Fedoruk hospitalizing me originally. So, yeah, for sure, you know, we have an iron test done, and you know, when I had to go in for my iron infusions, I felt like $1 million when I left. And it makes such a huge difference. The other thing, and I think you touched on it briefly when we were speaking about the malnutrition that can happen in young kids, because you don't want to eat when it hurts, and your body would rather, you know, just somehow functions that way. I use the, you know, Boost or Ensure type drinks. They're full of like vitamins and minerals. 230-something calories. They have plus proteins, plus fiber versions of it. There's chocolate, vanilla, strawberry. They taste awesome when they're cold, like little melted milkshakes. And they're really easy to digest. And it's a good pick-me-up. So, again, if you're not eating because it hurts or you're just really tired, maybe you're not getting the nutrients as much as Dr. Fedoruk said before, that your body has an ability to be able to absorb that. This is like a little compressed snack. And you can have a whole bunch of them a day. And you know, when I was coming out of the hospital, I was living on those things almost exclusively, and they made a huge difference. And even now, when I take them, you know, to fill in between meals or whatever else, it's a great way to boost energy, and it's a great way to get nutrients and calories into your body without affecting your pain levels or anything like that.
Wonderful. So there's another question from Ivan, and he says, "How do I manage through the flares?" And my suspicion is part of that is related to the fatigue that you were just talking about, but I'm wondering psychologically, emotionally, how do you actually do that?
How do I do that?
Yep.
Manage through the flares? Huge part of it, at least 50% for me, is attitude. I mean, it's a fight. You know, this is something that is attacking your well-being and your quality of life, and stay positive. That's really half the battle. If you know that you can beat it, and that there are things that you can do to assist with that, whether it's drugs or nutrition or your doctor or support groups, makes a huge difference for me. That's the biggest thing. Everything else, I mean, we spoke about, it's, you know, the food and the meds, whatever, but keeping a positive attitude and knowing you're not alone, and there's a lot of people out there that are going through exactly what you're going through, have and will unfortunately have to go through in the future. And, you know, it's strength in numbers that people have been sick just like you, and they get through it.
Okay, great. There's a couple of questions that are related to progression. So the first one is, can ulcerative colitis develop into Crohn's disease?
The basic answer to that is not. It's either ulcerative colitis or Crohn's disease right at the start. There is a very small number, 2 or 3 out of the 100 people, the doctors have a hard time determining if it's ulcerative colitis or Crohn's, and they may change their mind, but basically it starts as one disease and will stay as one disease.
Okay. And in the same vein, we're also being asked, is there an additional risk of developing colon, stomach, or esophageal cancer?
So with inflammatory bowel disease, there is an increased risk of cancer. That increased risk is mainly in the large intestine. And if you have ulcerative colitis, there's an increased risk of colon cancer that comes after about 10 years of the ulcerative colitis. And similarly, if you have Crohn's disease that involves the colon, there's that same increased risk of colon cancer that comes after at least 10 years of the disease. So another reason to stay connected with your doctor, who will know what to do and how to minimize that risk and prevent that risk for you.
Okay, great. Again, several people have asked essentially the same question, and that is, what is the potential side effects of anti-TNF therapy, especially from this individual, for pediatric patients who has a son who's sick?
Again, I mean, I can answer that to the best of my abilities. The anti-TNF therapy is near the top of our pyramid. So it can be very effective, but it does come with some risks, and those risks are mainly with an increased risk of infection. So we're really careful to watch people for the development of infections when they're taking these drugs. And that usually means monitoring them carefully in the office, monitoring blood tests, monitoring how they're feeling. We are using biologic agents, the anti-TNF biologic agents, Humira, Remicade, in both pediatric and adult patients. They're very effective drugs, and when used appropriately, can be life-changing for patients.
Okay, great. And the next question is for Jeff from Taha, who asks if any of your children have IBD.
No, thank God, no. I got 4 boys, 11, 9, 4, and a year. And, it's something that's always in the forefront. Everybody loves their kids more than anything. And my 11-year-old, the past maybe year and a half, he hasn't, thank God, shown any signs or symptoms like that, but he'll spend a little more time in the bathroom than I'm really comfortable with. And I think I might just be very sensitive because I'm watching for it, but as of yet, thank God it hasn't happened.
Okay, great. And then Colleen is asking if you know, either one of you, about the effects of marijuana on Crohn's disease.
Doc, you want me to answer or you want
Well, I'll answer from a medical standpoint. We've not been able to, while we have looked at it multiple times in multiple studies, we've not been able to show that marijuana will, either medical marijuana or smoking marijuana will heal, change, or alter Crohn's disease or ulcerative colitis.
Okay. And then another question is, should I be taking any probiotic supplements? And if I should, which ones should I take?
Jeff, are you on any probiotic supplements?
You know what? I like the probiotic yogurts, but nothing. I've seen, actually, I'm in the States right now when I was calling into this, and they have a whole slew of stuff that you don't find in Canada that's on here that are like probably exactly that, a little probiotic pill that you take on a regular basis. It's actually branded as a Crohn's disease like therapy over the counter at all these places, but I've never tried any of them.
So there is evidence that for more evidence for ulcerative colitis and less so for Crohn's disease, that probiotics are healthy and helpful. There does appear to be good bacteria in your intestine and bad bacteria, and it does appear that adding more good bacteria with probiotics are effective in reducing some flares and maintaining remission. There's 2 probiotics available in Canada that have been studied the most and have demonstrated in good scientific studies their effectiveness, and that is a probiotic called VSL3 Inc., and the other one is called E. coli Nissle, Nissle. Those are the names of the probiotics, and those are the ones that, if someone asked me about, have the most scientific evidence to suggest their effectiveness.
Okay, great. There's one question that all it says is, how long can I live this way? So I'm going to interpret that as being, is my life going to be shortened because I have IBD?
Is your life going to be shortened? The answer to that is, if you look at actuarial tables, no. In 2000, your life span will be the same. Your quality of life might be different, and that's why we're aiming to see you, treat you, manage the patients with IBD so they can maintain a good quality of life.
Okay.
I'd like to add in one just small caution that as much as, again, I'm no doctor, but there's a lot of symptoms that go left untreated, or if left untreated, I think would adversely affect somebody's health, would they not? I think it's, Crohn's may not be a killer disease in and of itself, but I think if people just let it slide and they don't get proper treatment from their doctor and they either mess around with their meds or they don't take it, I think that they're taking some serious health risks, wouldn't you say?
Yep, that's absolutely true, Jeff. So not managing your Crohn's disease, yes, or ulcerative colitis will shorten your life as long as you're managing it well and taking care of those problems, the anemia, the low iron, the low B12. That's what's important.
Okay, great. And this will be the final question. And again, this is one that's come from several people asking about what's the latest research and or what are the new treatments that are available or coming up that we haven't heard about yet? Is there any hope on the horizon?
So on one of my pictures, the pyramid, one of the at the top, there was something called experimental therapy. So, yes, absolutely, there are many new medications being investigated. Some of these medications are still in clinical trials. Once the clinical trial is completed and we can determine exactly how effective these medications are, they will be available to the public and physicians by prescription. So it's a rapidly changing time in the treatment of Crohn's disease and ulcerative colitis, and I would encourage the audience to stay tuned for new medications and exciting new developments in the next several years.
Cass, can I ask one question?
Mm-hmm.
I had a couple people ask me, and it relates to this last question. As far as stem cells, is there anything on the horizon with stem cell research?
Dr. Fedoruk, that would be you, not me.
Yeah, so we are running in Canada 2 stem cell therapy trials. Patients should connect with their doctor. So stem cell therapy is taking baby cells and trying to grow new intestine. And it's a promising new treatment. It has helped some people, but still needs lots of work, Jeff, before it would be available for the public. The problem with it is in order to prevent, it's like a transplantation. In order to prevent rejection of these new stem cells, you do need to take strong medications. So it's a risk-benefit, and we're still studying that and trying to learn more about that.
Is that like a 1 or 2 year time horizon, or more like a 5 or 10 year time horizon?
It's about a 5 to 7 year time horizon. The other medication I talked about is a 1 or 2 year time horizon.
Okay, and then I would also encourage everyone to continue to check back at cdhf.ca because we're going to be putting information up on a regular basis, and as new information becomes available, we'll let you know about it through our newsletters. So on behalf of the Canadian Digestive Health Foundation, I'd like to thank Jeff and Dr. Fedoruk for sharing their insights and expertise with us, and to extend a very special thank you to you for joining us. We hope the session empowers you to live positively with IBD. And this concludes our session.
Thanks.
Thank you, Catherine, and good night, everyone.